Hello, everyone, and welcome to today's third Optimizing Antimicrobial Stewardship webinar. My name is Tina Schween. I'm a Quality Improvement Consultant at Qualis Health, and I'll be your host today. In terms of logistics, I just wanted to remind everybody that lines will be muted during the presentation, and we'll take them off mute when it's time for opening up for discussion. But in the meantime, if you have questions or comments, please feel free to type them in the chat section. You'll see in the lower right-hand corner of your screen a area where you can type into. And just be sure that the Send To drop-down menu says All Participants. You can type in there and hit Send. We'll be able to see that chat and address those comments and questions as we move forward. As a reminder, Qualis Health is working with a number of hospitals in Washington and Idaho through 3 different HAI action networks. The Optimizing Antimicrobial Stewardship series is part of the CDI action network. Before I introduce our guest speaker today and our panelists, I just wanted to give a quick note that the CDC recently released a new vital signs report and a series of resources regarding Clostridium difficile infection. This slide gives you those relevant links, as well as it highlights sort of 3 overarching messages from that report. One is that hospital stays associated with C. difficile are on the rise, that nearly all C. difficile infections are connected with steady medical care, and that hospitals following infection control recommendations can, in fact, lower rates. And then I just wanted to note that within that vital signs report, they list 6 steps for preventing CDI, and I thought it was interesting that the very first one has to do with antimicrobial stewardship. The first one is prescribe and use antibiotics carefully. So as I mentioned, this is the third in a 4-part series of Optimizing Antimicrobial Stewardship, and today we're going to be traveling virtually to Harborview. Our next step will be in April, and during that one we'll be traveling to St. Mary Medical Center in Walla Walla. But today our focus will be on Harborview. Our agenda today is very similar to agendas in the past. I'll do some quick introductions, and then we'll jump on the bus and head to Harborview. After the presentation there, we'll have 2 panelists from the Antimicrobial Stewardship Committee of Seattle give some initial reactions and comments. And then we've carved out more time today, hopefully, for discussion, questions, and comments. So, our guest speaker today is Dr. John Lynch from Harborview Medical Center, and our expert panelists from the Antimicrobial Stewardship Committee of Seattle are Dr. Mike Nick and Rupali Jain. Mike Nick comes from Virginia Mason Medical Center, and Rupali joins us from the University of Washington. And with that, I would like us to, again, have time for comments and discussion towards the end, so I'm going to cut my intro short, and I'm going to hand the ball over to John. And I'd encourage us all to jump on the bus and join him as we travel to Harborview. John, take it away.
Thank you very much, Tina, and thanks to Qualis for inviting me to speak and for setting this whole webinar series up. I've had a very enjoyable time listening to my colleagues from Swedish and most recently Yakima Memorial speak recently. It was just great to learn some lessons from each of them. So basically today, in the next, 40 or so minutes, I'm going to try to share what we've done at Harborview over the last few years. I just want to let everyone know that I'm also joined here by Jeannie Chan, who's my colleague in pharmacy. The 2 of us make up basically the antimicrobial stewardship team, and she'll be available for questions at the end. So just to get started here, I wanted to bring up, this is actually Dr. John Pauk's slide from the Swedish presentation, the very first presentation, sort of just defining stewardship. I think it's a really nice way to start framing these discussions and these talks. I especially like that second part of John's presentation, the moral and ethical responsibility for caretaking on behalf of others. So I think it really lends itself very nicely to healthcare and how antimicrobial stewardship lends itself towards better patient outcomes. So just a quick reminder there. And just overall stewardship approach, this is from a series published by the CDC back in 2008. which focuses on why antimicrobials or antimicrobial misuse is a big problem. And I just want to sort of remind everyone of the overall problem and what we're trying to address here at Harborview. You can read all those for yourself, but some of the other pertinent data includes estimates of up to 50% of all inpatient antimicrobial use is inappropriate. And that clearly recognizes that there is probably something going on in the outpatient setting, which we at Harborview haven't really begun to address, but it's certainly an under-addressed area in antimicrobial stewardship overall. In addition, there's almost 150,000 visits to emergency rooms related to adverse reactions to antimicrobials. They continue to be given when they're not needed, when they're not necessary, often the wrong, I shouldn't say often, but frequently the wrong dosage, very broad spectrum of antimicrobials, or the wrong bug-drug mismatch. So I like that last part, the last line there, talking about antimicrobial stewardship or appropriate use of antimicrobials as a public health imperative. It's one of the few places where if we use a drug for one person, it definitely has an impact on others. I'd also just like everyone to be aware that the Infection Control and Hospital Epidemiology Journal just came out with a whole edition dedicated towards antimicrobial stewardship. Again, I won't read this quote off, but if we go back about now 50 years to an article by Dr. Ryman quoting the following: much needless expense, untoward effect, harm, and disappointment can be prevented by better judgment and use of antimicrobials for prophylaxis and therapy. So after 50 years of people recognizing the antimicrobial use leads to bad outcomes and increased drug resistance, we are continuing to struggle with this problem, as can be illustrated in this most recent edition. I highly recommend people take a look at it. Some very nice articles that address this overall situation. So on to Harborview specifically. For those of you who don't know about us, we're a 413-bed county hospital located in Seattle on First Hill, right next to Swedish or Virginia Mason. We're a major teaching hospital at the University of Washington. We have over 500 faculty that are dedicated to Harborview, but more that come from other sites, including the VA and the University of Washington Medical Center. And at any one time, we have several hundred residents spanning pretty much every discipline you can imagine on site at any time. Specifically in terms of infectious diseases, we have almost 100 faculty members in that division alone. And the reason I bring that up is because we have lots of infectious disease doctors rotating through here. Some of them only spend a few weeks a year on the service. And you can imagine how people's opinions can span the whole spectrum of possibilities when that happens. And I think it also informs sort of the approach we've taken here. We're a level 1 trauma center for both adults and pediatrics, the burn center for the Washington, Wyoming, Alaska, Montana, Idaho region. We have a lot of psych beds. We have a large rehab facility as well. And we also have almost 90 ICU beds. So we have a very large critical care population that has certain risks associated with hospitalization as well. We have about 60,000 ER visits a year, and in 2010 we did almost $190 million in charity. That photo down the left lower side there is kind of down from the Skid Row section. We serve a lot of homeless folks and highly at-risk populations here at Harborview, as well as the trauma, burn, and similar populations. Antimicrobial stewardship has been depicted in many different ways. This is from an article by Neil Fisher back in 2006 with the COG at the center. I would say that the important connection we have here at Harborview is this one we have with infection control. Both Jeannie and I sit on the infection control group. We're pretty active in the day-to-day operations there. And the leaders of the infection control group are in communication with us regularly. And we've sort of taken that as a major model for practice of antimicrobial stewardship here at Harborview. This way we're aware of what's going on in the hospital, what type of multi-drug resistant pathogens are arising, what the C. diff rate is, which is especially pertinent to this series. In addition, we also work with a number of other groups, and you can see kind of going around that circle with our microbiology colleagues looking at improved diagnostics, the P&T committee looking at drugs and vaccine use, looking at areas of education, which is a really big issue for us, given how many residents, fellows, and transient faculty members we have coming through, and then this idea of benchmarks, which I'll address later on in the conversation. Here's another article, a graphic again from Neil Fishman's article back in 2006. And just to kind of put it in rough terms, Jeannie and I in the Antimicrobial Stewardship Program are sort of that green box at the top, where we know a lot about infectious diseases, we know a lot about antibiotics, so we try to know a lot about the patients when we make interventions. And in the areas where we try to make interventions are those ones in red boxes, looking at physician attitude, decision-making processes, decisions about which choices, refining choices, integrating cultural results, all with the effort of rational antibiotic use. There is a missing box to the patient's attitude and desires, which we haven't addressed, but certainly with comparative effective research in the future may be something we can think about including as we move forward. So, our history, back in 2000, we basically had no program. In 2001, antimicrobial stewardship was introduced as a big process improvement project by Tim Dellett and Jeannie Chan and Matt Hooten here at Harborview. Around that time, and this is probably a similar situation in a number of other facilities, there's a lot of oblanazole use going on. There's a lot of imipenem and other carbapenem use. And as people recall, we were in healthcare at that time. There was a very large community-acquired MRSA explosion, both people coming from the outpatient and inpatient setting. As a result of that process improvement project, in 2003 we had one ID physician and one ID pharmacist who were approved. And the basic practice at that time was daily review of cases that were collected by the ID pharmacist. This included a lot of groundwork and discussions with the clinical pharmacists on the floor who are partners in this process. We never have had a restriction on antibiotic use. No one ever had a call to use antimicrobial here at Harborview, and that continues to be the case. Jeannie and the other members of the pharmacy group continue to track total antimicrobial costs, days of hospitalization, PICC line use, which I put with an asterisk there because we have a very large trauma population, which leads to a lot of people with endocarditis and osteomyelitis requiring long-term antimicrobials. And so the use of antimicrobials in outpatient antimicrobial settings has been a big issue for us as well. And then Jeannie's also looked at savings versus FTE. In cooperation with the floor pharmacists, we've looked at IV to PO conversions as a big opportunity. And then we also participate on a large joint infectious disease P&T committee, Pharmacy and Therapeutics Committee with our colleagues at EWMC, Seattle Cancer Care Alliance, as well as Harborview. I'm going to illustrate the next point, development of VAP guidelines is sort of one of the major pushes we've had with antimicrobial stewardship here at Harborview as well. Again, bringing in this big educational piece as a critical part of our program. And then initially, for the first 2 years, there were monthly meetings to review finances. And I think this is a big driver in establishing the program both as an important intervention and as a cost-saving measure, but also to demonstrate its validity in terms of interventions and really made its reputation as an ongoing process. Because of the success of those early interventions and reviews, the antimicrobial stewardship program has been essentially self-renewing without necessarily close administrative oversight since then. I will also say that as a part of our academic mission, Tim Dellett, as the first author on this paper, including authors from all over the country, put out the first guidelines in 2007, I believe. This was published in Clinical Infectious Diseases back in 2007 as the first guidelines for antimicrobial stewardship. And I think still has a lot of excellent take-home points, which have been updated in that new ICHE article. So, where we are is in evolution. I think any antimicrobial stewardship program is not finalized. I think Swedish model, John Popp and others there have really demonstrated, I think, as I keep saying, it's a kind of a gold standard model for audit and feedback and evaluation using really up-to-date IT tools to get that done. I would say that we're, not quite the same as Yakima Memorial, we're not quite the same as Swedish, but we're somewhere in the middle of those two programs and how we're integrating all these different tools that are available. Right now, we are using some decision support software at Theradoc, like Swedish, and the Microsoft Amalgam project, and I'll show you some demonstrations of those a little bit later in the talk. We use a lot of surveillance data in cooperation with our infection control colleagues to focus our efforts as persons Clostridium difficile and for feedback to clinicians. This has been extremely powerful to be able to provide real data and real-time data to our colleagues, both with the emergence of drug-resistant pathogens, but also antibiotic use over time. We also are integrated, as is infection control, into our quality improvement and patient safety effort. So again, using the terms and philosophies of those efforts have been very valuable in communicating with all the different stakeholders in our hospital. And then we also play a role in our surgical care improvement program, which helps facilitate the appropriate use of prophylactic antimicrobials before types of surgery, early discontinuation as appropriate. So on the front lines right now, we have very tight collaboration. Jeannie and I talk regularly about what's going on. Jeannie gets a lot of input from the clinical pharmacists and is able to provide real-time feedback to those clinical pharmacists and the teams as necessary. And then I can provide clinician-to-clinician education interventions as we go through the day or in larger processes like the one I'm about to describe. We're also very active in our order set review and guideline review. We are not yet a CPOE hospital, computerized physician order entry hospital, but that process is actually underway. The University of Washington, our sister institution, will be doing that this spring, and then Harborview will be doing it, I think, late summer, fall. And we've played a role in working on those order sets so that the antimicrobials are appropriate in terms of choice and dosing. And then obviously, I think for any AS program, often serve as a resource for any antibiotic questions. We have a very active infectious disease service, which serves as the consult service. But if there's certain specific questions that come about drug dosing, Jeannie and I try to take those on a little bit, and then if necessary, refer them back to the infectious disease service for more involved consultation. The next slide is our program structure, and I did this because both the Academy and Swedish did. It was very nice to be able to see how antimicrobial stewardship fits into the larger administrative schema. So here at Harborview, we report to the Infection Control Committee, which is a very large body here at Harborview, which includes lots of members from all over the hospital. We also are tightly linked to the Infectious Disease Clinic and the OPAT program. I'm the medical director for the ID Clinic, and so I see a lot of patients in the outpatient setting who are transitioning from inpatient to outpatients with tick lines and other complicated antimicrobial prescriptions. As I mentioned, we sit on the ID P&T Committee, which answers up to the university-wide P&T Committee, which includes the University of Washington Medical Center, SCCA, and Harborview. We work on care protocols and pathways for working on CPOE. And you see that dotted line to the green box at the right lower side, UWMC. My colleague Rupali Jain, I know, is online as one of the moderators here. We work with both Rupali and Paul Pottinger on the UWMC team so that we can sync as much as we can in terms of antimicrobial stewardship practices, even though we're two very different institutions. And then lastly, we serve as, you can provide teaching wherever possible. We work on the surgical care improvement program and obviously serve as the antimicrobial resource as needed. So as of today, the focus is really reviewed by clinical pharmacists and by Jeannie, our antimicrobial stewardship pharmacist, looking at bug-drug mismatches, potential de-escalation interventions, looking at areas of overlapping antibiotic coverage. Particularly, we've seen here is a lot of double anaerobic coverage, drug dosing, IV to PO conversions. The last one, IV to PO conversions, we've empowered the clinical pharmacists to work on that themselves. We try to collect data on it with a IV to PO conversion form that we continue to try to reinforce as a way to collect data. But that's been quite successful for our clinical pharmacists with backup from the antimicrobial stewardship program as a important maneuver. We review surveillance alerts using some of our both our clinical pharmacist inputs, but also these new IT tools, both Microsoft Amalgam and the Theradoc tool. We discuss complex interventions and challenges to interventions as a team, and then where it requires physician-to-physician communication, we try to jump on that as soon as possible so that we can talk to the team, provide that necessary education, talk about availability of guidelines in order to standardize treatment. As I mentioned, we have a lot of infectious disease clinicians here, some of whom don't spend a lot of time on the service and may not be as up-to-date with guidelines, and we often take the opportunity to make sure that our infectious disease guidelines are easily accessible and are utilized by all of our infectious disease physicians so that they're getting uniform, at least our specialty services and primary care services are getting uniform recommendations from our infectious disease consultants. We collect VAP pathogen data as part of our infection control role here at Harborview, and that's really spearheaded by Jeannie Chan, and then look at antibiotic cost guidelines, clinical pathways, and CPO review. So the P&T committee, this is one of our major interventions we've had, looking at drug inclusion on our formulary. So instead of restricting at the use level, at the clinician use level, we have decided to hold off including some antimicrobials for overall use at the formulary level. This has been quite useful for us in terms of control of antimicrobials. I'll show you a couple of demonstrations here shortly. I will say, for example, we've decided in the last year to hold off adding ceftaroline and fidaxomicin to new antimicrobials to our formulary. Both those are available to our clinicians. They're just not on a formulary for immediate use. So just quickly to go through a couple of examples in the last couple of years of how we've used the P&T committee to control antimicrobial use. The first one at the top, the kind of Camden class review, it was recognized that caspofungin had more drug interactions and tended to be more expensive. And so in 2007, we replaced caspofungin with microfungin, removed caspofungin from our formulary, and that in 1 year had a very large cost savings of nearly $500,000. And so we had equivalent patient outcomes with big cost savings to the institution. More recently, we reviewed carbapenems. We have traditionally used a fair amount of carbapenems, both imipenem and meropenem, which have similar spectrums. But at the time we did this review just over a year ago, imipenem remained much more expensive than meropenem. And so we reviewed all of our microbiology data. We were able to find essentially 97 to 98% overlap with drug susceptibility patterns with these two drugs. And so we removed imipenem from the formulary and put in an automatic meropenem substitution for any of those orders, with the understanding that if the clinician wanted imipenem, it could still be done generally within several hours. The projected savings at the time we made that change was in the several $100,000 range because imipenem was still not generic. Since then, it has gone generic. And so the cost savings have been smaller, but still significant at about $70,000. A slightly more complicated intervention, but I think and it's still evolution, but I think it's been a very useful intervention for us as a program, is this idea of using piperacillin and tazobactam as a prolonged infusion. So typically this drug, Zosyn, is given every 6 hours over 30 minutes. But there's been some very nice studies looking at prolonged infusion, where you use the same dose, 3.375 grams, over prolonged infusion of 4 hours every 8 hours, with similar outcomes in critically ill patients. And so you automatically cut the drug dose by about 25% with the same outcomes for patients. The challenges for this is that you need 12 hours access to a line, and so it's been very important to have RN education and RN buy-in to sort of take up that real estate for lines. The UNMC was really out front in doing this and has been very successful. Here at Harborview, we rolled it out in the last 6 months or so, and we're still working out some of the kinks, but it's been very useful for us, and the projected savings is also in that $30,000 to $40,000 range. So moving to a slightly different mechanism that we use here at Harborview, and this is, I think, a little bit different than what you may have seen at Yakima Memorial or Swedish, although they do similar processes, is this idea of using interventions as education and influencing how people make both diagnostic maneuvers and treatment decisions. So, as I mentioned, we have a lot of ICU beds. We have lots of intubated patients and lots of people intubated for a long period of time. We know that ventilator-associated pneumonia is a major complication of ventilated patients. It's one of the most common ICU-related healthcare-associated infections that leads to increased mortality and length of stay, and is also associated with a lot of MDROs. So we initially started looking at these pathogens back in 2003, and these are basically microbiological specimens that meet criteria for VAP obtained by bronchoscopy or mini-BAL. And you can see in the first column on the left the microorganism. The second column are the proportion, both the number and proportions of those microorganisms associated with early onset VAP, which is defined as less than 5 days of hospitalization or endotracheal intubation. And then the last column on the right, late onset pathogens, and that's basically defined as 5 days or more of hospitalization plus minus days of endotracheal intubation. And you can see that in the second column, the early onset is dominated by MSSA, Haemophilus, and strep pneumo, and that the late onset, if you move down that lower half, a lot of MRSA, a lot of Acinetobacter, followed by alpha hemolytic strep and MSSA. So that was basically 2003, and so as a result of this epidemiological analysis, the decision was made in cooperation with critical care docs, both in surgery and medicine, pharmacy, infectious diseases, and our critical care docs in medicine, to develop a set of guidelines that would put into place appropriate diagnostics and treatment for VAP. And that's just demonstrated here. This was made up into a card, which is distributed to all the clinicians and the residents, and as is common, that card fit nicely into the pocket of the residents, and that's where it stayed. So there was an improvement in diagnostic and treatment guideline adherence for a period of time after that, but it didn't really continue indefinitely. In recent review, we were able to show that, for instance, treatment for early VAP followed these guidelines in less than half the time, about 44%. So frontline clinicians, often residents and fellows, were using inappropriately broad spectrum antimicrobials for early VAP, which, as we showed epidemiologically, was mostly MSSA, H. flu, and strep pneumo, which could be treated with, fairly narrow spectrum antimicrobials. So between that time and now, we've done a lot in terms of infection control, VAP prevention mechanisms. So you don't have to read all these going across, but as the data has emerged, more and more VAP prevention mechanisms put into place, including active surveillance swabs where patients are screened when they come into the hospital, and then every week, CHG, chlorhexidine baths of people's bodies, kind of bed elevation, spontaneous breathing trials, up to the point that we have a evidence-based VAP prevention bundle in place. Basically, as of 2009, with all through 2009, 2010, auditing of adherence to that bundle, all elements. And currently now is monitored electronically, so the nurses know what needs to be done and what hasn't been done so far for their patients. So between that time, 2003, where we first looked at the pathogens, and now, there's been a lot has changed in terms of our ICU infection control practices. So we thought it would be a good time to review the VAP pathogens to see whether anything has changed. So here's a similar table as that one I showed you with VAP pathogens early and late, except that here we're looking at pathogens in the first column, that early distribution in the second column, and then the distribution of early VAP pathogens in the third column. So you can see July 2003 to June 2004, about a year of pathogens in that second column, and 2 years of pathogens in the second column, up to June 2010. We've actually gone back and looked at this since then, and it's still consistent, with MSSA, H. flu, and strep pneumo being the most common pathogens isolated early VAP. So again, recognizing that a lot of early VAP treatment was inappropriately broad, we know that we needed to target this as a change in antimicrobial treatment. We also looked at late VAP, and surprisingly and pleasantly, we were surprised to find out that our epidemiology has changed quite dramatically since 2003, 2004. And you can see here several years ago, from 2008 until June 2010, showing that those multi-drug resistant Acinetobacter infections, the MRSA infections, have dropped dramatically from being the two top causes of late onset pulmonary-associated pneumonia to some of the lowest ones. In addition, MSSA has risen to be the top pathogen associated with late onset VAP, and Pseudomonas has sort of occupied that gram-negative niche. So we had new epidemiology associated with the late VAP here at Harborview, and the late VAP is overwhelmingly the largest number of VAP cases we have at Harborview. You can see at the very top there, if you look over from 2008 to 2010, just under 200 cases of late onset VAP compared to early VAP, which is in probably 40 or 50 per year. So obviously we have the problem with early antimicrobial use, or antimicrobial use being inappropriately brought for early spectrum or early VAP, and a big change in our pathogens for late VAP. So really opportunity to do something here. So you can see that with only a few cases of MRSA VAP per year, you can see in 2009 and 2010 only two. Most people who treat late pneumonia-associated pneumonia use vancomycin in combination with a fairly broad-spectrum drug like carbapenem, Piptazo, or cefepime. But that means that nearly 100 people a year are getting vancomycin for a disease that they are at very, very low risk for, even with late-onset VAP. So the question then was, what can we do to decrease vancomycin use? I mentioned it as part of our infection control bundle in the intensive care units. All of our patients are swabbed at admission, that's day 0, and then every 7 days after, we audit those active surveillance swabs, and we know that the nurses are doing them over 90 to 99% of the time. We check for MRSA, and we check for multiple spots, including the nares, the endotracheal tube, and any wounds, VRE from the rectum, and Acinetobacter from the ET as well. This is all ICU patients every 7 days, and people who have a positive active surveillance culture from any of those sites or any of those pathogens go into contact precautions or are cohorted with people with similar pathogens. So here we have a infection control tool, and the question is, now we know who may be colonized with MRSA, and the question is, can we use that for a diagnostic intervention? So we actually looked at this as basically a laboratory test and decided to evaluate positive predictive value, negative predictive value, sensitivity, and specificity. And you can see in that the kind of bright blue in the top right there, the positive predictive value of a positive MRSA surveillance swab was not very good, only about 36%. But right below that, if you had a negative MRSA swab from the endotracheal tube, the nose, and any wound, the negative predictive value was nearly 100%. Basically saying that if your swab was negative, the chance of you having MRSA VAP was extremely low, less than 1%. And so here we all of a sudden had a tool that we could use to decrease vancomycin use for all those patients who had very low risk of MRSA. We also wanted to address carbapenem use, and you can see here in red that this go-to drug for late VAP, imipenem and meropenem, often used in combination with vancomycin, wasn't actually the best drug to use empirically for late onset VAP. And so we looked at our Pseudomonas drug susceptibility, and remember Pseudomonas was our #1 gram-negative rod for late onset VAP, that all this empiric use of imipenem, meropenem, which includes potent anaerobic coverage, wasn't necessary. And in fact, cefepime was a more important or more useful drug in that setting for empiric treatment. And so we were able to show this type of data to our colleagues in various venues by providing education, slide sets, and teaching. And very quickly we were able to influence both our vancomycin and carbapenem use drastically. In addition, we wanted to hardwire this a bit better, so we decided to institute or really update the old VAP guidelines. And this time, instead of providing a pocket card, actually provided as an order set. And so what you see here is a diagnostic pathway, with the idea being that anyone on a medical care team, the bedside RN, the respiratory therapist, the medical student, resident, fellow, or attending, can simply look at this order set, which has this diagram on the back looking at whether the person has radiographic evidence of pneumonia, fever, endotracheal secretions that have changed, leukocytosis, They basically march down this pathway, move to bronchoscopy or mini BAL if bronchoscopy is available, assess their multi-drug resistant organism risk, the days of hospitalization, move to whether this person, to stratify that person to whether they need treatment for early VAP or treatment for late VAP, and then again reassessment. You can see in that lower box after 3 days, so the clinician actually goes back and reviews the microbiology and makes a decision about what needs to be done. And so that flow sheet is actually in the back of this order set. So this is day 0, again asking the same question. Does the person meet criteria for ventilator-associated pneumonia? Let's get to bronchoscopy or mini BAL. Let's stay away from empiric treatment, and gives them data here in terms of, or data-driven antibiotic choices to choose empiric treatment. We incorporated, as you can see down under the MRSA part, if MRSA surveillance swab is positive or unknown surveillance status or clinically unstable. And you can see the same thing in the late VAP section there as well, that if your MRSA swab, that active surveillance swab, which I described as having a very strong negative predictive value, is negative, even with late VAP, 20 days into your hospitalization, including vancomycin is not necessary. So someone with late VAP who's at risk for drug-resistant Pseudomonas can get something like cefepime empirically, hold on the vancomycin, and be monitored, which is a big change from our prior practices here. In addition, we try to reinforce the appropriate dosing of antimicrobials, the appropriate choice of antimicrobials for early VAP in that early VAP section. And then on the day 3 reassessment, at the top, we ask the clinician to evaluate whether the cultures are sufficient to support the diagnosis of ventilator-associated pneumonia, and if not, that second checkbox to stop targeted antimicrobials. If they continue to choose, a drug that they think is appropriate for that pathogen and the drug susceptibilities that are available. So here, really driving the appropriate diagnosis and the appropriate antibiotic use, and then appropriate choice of antibiotics. And although you can't see it here, there's also a checkbox in the bottom for the number of days. So if you have Acinetobacter, Pseudomonas, or other multi-drug resistant gram-negative rod, that you'll be going for 14 days or 15 days versus 8 days for a gram-positive. So the VAP oversight was really a multidisciplinary approach. We started sending this data out, presenting the data, and we had a big change in our drug use. We replaced imipenem with cefepime based on our local epidemiology. We were able to markedly decrease empiric vancomycin use based on the active surveillance cultures. And just looking at just the drug use alone, not patient outcomes, not days in the hospitalization, not adverse events, the estimated cost savings is about $130,000 simply by using the right drugs. Moving on, we also, trying to adopt information technology, we are fortunate to have excellent information technology support through our collaboration with infection control colleagues. And we're using 2 products, as I mentioned. Microsoft Amalga, which has the benefits of easy customizability by our IT people, a simple interface. It doesn't record interventions, however, like Theradoc does. It doesn't link to other patient information. So you only get what you can see. And I'll show you an example of that in a moment. Versus Theradoc, which we're still just learning on. We just brought it on board for our program in the last 4 months or so. Here, customization is more complex. It's a shared resource between multiple institutions, and its customization is done at the higher level, at the company level. It does record interventions, however, and has the ability to record cost savings as part of your interventions. And then it links to other patient information, which I'll show you here as well. So here's a typical alert that comes from Theradoc. I remove the patient identification information, which is generally included with this. But you can see at the top you have age, you get a serum creatinine clearance, weight, height, so forth. So you get some very nice basic data. You get what triggers the alert, in this case lower respiratory culture with gram stain showing coag-positive staph. It gives you the date and time when it was ordered, an accession number. Here we have the drug susceptibilities, and it was this bug-drug susceptibility mismatch that triggered the alert. So this person is down here on vancomycin, as you can see at the bottom, and this particular specimen was MSSA. And so the alert here fired saying that if a person here doesn't need vancomycin, it could potentially be on a simpler non-MRSA regimen for effective outcomes. In addition, you see down here medications, lab review, and microbiology review, which again links to other patient information. And so this is really nice, very powerful. You can get to lots of information very quickly. We're still working on how to trim our interventions, our alerts, so that we only get the ones that we really want to focus on. So this is a process in evolution. Here's two examples of what Amalgam looks like, which is basically incredibly powerful Excel spreadsheet in many ways, where each column is drawn from multiple computer sources or IT systems. So for instance here I blocked out in the light blue the patient name and other patient identifiers. But here in the top box, I'm basically asked for everyone in the last 24 hours who's had a vancomycin trough greater than 20. You can see here just a few patients, so I know whether I can monitor high vancomycin troughs in patients here. But it doesn't provide links to any other patient information. In this bottom box there, this simply gives me a list of everyone who's on a carbapenem in the last 24 hours. Again, I get some basic information where the person is, where they got their doses, but no other patient information. In addition, it gives me in this list pretty much every dose the person gave, so these aren't all individuals. And so it's not quite as user-friendly in some ways, but does provide very clean, easy data for very quick interventions that's updated on a 24-hour basis. So we also looked at metrics, and because I'm running out of time, I'm going to just move quickly to what we're looking at in terms of hard data in terms of our outcomes. So we're part of the University Health Consortium, which is a large number of hospitals, nearly 350 hospitals, to report lots of data to UHC. And basically what I want to show you here is that Harborview, where we are, is basically these light kind of salmon color boxes, where we fall in comparison to all of our other colleagues in UHC and antibiotic use. And what I do want to say is that we're in the lower 50 percentile for almost all antibiotic use, including carbapenem and linezolid, which means that we're using less of those drugs than half the hospitals that are included in this consortium. Where we are using more of them are drugs like cefazolin, which is great, and clindamycin, which is just over the 50th percentile, which is commonly used in our necrotizing fasciitis, kind of quad cocktail. We have a lot of those patients here, and we probably use a lot of clindamycin as a result. So we're able to benchmark what we do here at Harborview to over 300 hospitals across the country to figure out where we are. In addition, like a lot of hospitals, we look at cost. Here in red bars is total pharmacy cost per patient day, and in blue bars is cost of antibiotics per patient day. That last set of blue bars for FY 2012 is incomplete, so that's why it's so different than the others, because we're only partway through the financial year. But right now we're looking at about $15 per patient day in terms of antimicrobial costs. We're able to keep that fairly steady over the past few years, even with rising overall pharmacy costs. So it's been, I think, a positive relationship between Harborview and the Antimicrobial Stewardship Program with very good interventions that have led to cost savings and good patient outcomes. So I think I'm going to finish up there. I mentioned this Antimicrobial Stewardship Journal, which you should take a peek at when you get a chance. And I'd like to thank my colleagues at UWMC here at Harborview, CDC, and of course the Antimicrobial Stewardship Consortium of Seattle. Thanks. I'm going to hand it back over to Tina now.
Thanks so much, Dr. Lynch. Great presentation. I am going to advance. There we go. Got control back. I'd like to reintroduce Rupali Jain and Mike Mint, our two panelists today, and I'd like to invite them now to give us some just initial reactions to what we heard about Harborview's approach. And after their initial reactions, I'll ask the operator to open lines for folks to kind of get in the queue with questions or comments you might like to share. I'd also like to put in a pitch if you would prefer to chat in comments, that's fine too. Rupali and Mike, take it away.
Mike, do you want to go first? Sure.
I'll go ahead, Rupali.
This is a great presentation, John. What really excited me, I think, is that looking at just some of those formulary changes and the price on there versus the amount that you saved with some of your VAT protocols, and how you guys were able to save so much more money with just this local data and influence practice in such a more impactful way. How do you guys go about generating some of these ideas for developing these guidelines or new projects and things like that?
I think that's a great idea. I mean, I think that
the VAP protocol, the most recent update we did with VAP was really a result of historical cooperative approach to treating VAP back, I guess 8 years ago now or no more. And so that part, and then also our role on infection control, being the ones who were online to collect that data, made it clear to us that that's someplace where we could do a lot of good and where we had data to make choices. We have a lot of ICU beds here, and we have a fair amount of VAP, so it was also a high priority item for us. And then lastly, there's data to support the interventions. There's data on improved outcomes with aggressive interventions like bronchoscopy and EBAL, and there's data on the appropriate antibiotics and data on appropriate length of therapy. So a lot of providers really respond to data-driven recommendations, and so VAP was one of those places where a lot of the pieces of the puzzle fell into place. I will say that right now, I cut the slides out, but we're also looking in exactly the same way we're looking at sepsis here. So we collect everyone who meets criteria for sepsis in Harborview, and we're looking at how to tune the empiric guidelines based on basically what the evaluation of the patient is, what their risk factors are, where they are in their hospitalization, and see whether those can impact appropriate antimicrobial use. Because I think there's a lot of inappropriately broad-spectrum antibiotic use for critically ill patients in the hospital. So we're basically just kind of building on that same model over the last 10 years.
So this is Mike Mintz. Again, I want to congratulate you on the work that you've done there. It's actually really remarkable, the scope and spectrum. And what's most impressive to me, looking at all the different talks, is just how unique each organization is in regards to its risk factors in regards to implementation of this kind of policy. And yours clearly is the diverse group of clinicians that you're interacting with. I really like the fact that your data is really integrated throughout lots of quality initiatives throughout the organization. And the local data, as we probably just alluded to, is really great because I suspect that would increase buy-in by the doctors. My question to you would be in regards to how do you then make sure that you limit the amount of different approaches once you start to implement these data and these protocols in place, and how are you going to monitor for that, and how do you see sustainability of this going forward into the future as these cards get lost in people's pockets?
Well, I think that's why we decided not to go with the card approach. So that the first iteration of the VAP recommendations was a card in the pocket. The second iteration, the one I showed today, is an order set. So to diagnose and treat someone, you just simply pull this order set out, and it tells you what to do based on our local epidemiology. So I think that part is hardwired into the system now, because I don't believe in the pocket guidelines. It just doesn't work. We've also spent a lot of time with education. I mean, and to be clear, before the order set went into place, our vancomycin use dropped and our carbapenem use dropped for VAP months before we ever put the guideline in place. So I think that the education part, the talk, the demonstration of local data is what drove change, and I think the order set is what's going to help hardwire it. But in addition, we collect that data ongoing. We update the major stakeholders, the critical care advisory committees, and so forth. But we also we made it very clear that this is a living document that's going to be changed based on our local epidemiology. Then lastly, we collect we know when people are getting bronch, we know when people aren't getting bronch. And I think this kind of goes to the first part of your question, is that we want to do a lot of things, for instance, the sepsis evaluation, but we don't want to become overburdened with collecting new interventions and demonstrating new interventions unless we can go back and show that the interventions we've already put into place are really useful. And so that's something, again, we've only put that VAP protocol in place in the last year or so, and so we're just about to start looking at how often is it being used, is it being used appropriately, how many people are not getting bronch, and then it's really peer-to-peer communication about why bronchs or mini BALs aren't happening, why people are deviating from data, basically.
Thank you.
Great. This is Tina, and if the operator could go ahead and open lines to folks who have questions or comments they'd like to pose to either Dr. Lynch or our two panelists.
Yes, Dr. Lynch, thank you so much. Dr. Puff and I enjoyed your presentation. Could you explain a little bit about how the ID physician and the pharmacist work together on either on a daily basis or how you review tough cases and how you communicate that information to your colleagues? And then in the second part of that, do you have any official documentation that you put into the medical record?
Well, I'll answer the second part first. So you guys have done a really nice job over at Swedish with using the alerts from Theradoc and then entering those interventions into the medical record. And I think we're moving that way. We are working in collaboration very closely with Rupali Jain and Paul Bottomir over at UWMC so that we're on the same page and doing the same thing. Because I think that the way you guys demonstrated this as a supportive measure for the interventions and uptake of interventions with the clinicians is really important. I just think that we wanted to do it at the right time. So we're not doing it yet. I think we're going to get there. But to do so requires a lot of time. And you guys at Swedish, again, have demonstrated really how to do this with the amount of time. So the upside to how we communicate is that it's the antimicrobial stewardship team for Harborview Medical Center is Jeannie Chan and myself. So it's the two of us. And so Jeannie and I talk all the time about what's going on, when there's particular things need to happen, where I need to have that peer-to-peer conversation. I'm also one of the only full-time ID docs here at Harborview. We have tons of ID docs who are all over the city, but I'm here at Harborview all the time. And so one of the real benefits about having an ID doc in here, besides the infectious disease knowledge, is that I take care of patients on every single service here, and I'm sure that you guys have the same experience. So I know all the clinicians that are involved, and so I feel really comfortable in calling them up, paging them, emailing them, checking on their patients to sort of talk about those interventions. I work with the surgeons very closely on the surgical care improvement program, so those personal relationships have really informed how I make those peer-to-peer communications. I do think, though, that part about putting in the medical record as a support mechanism really has a lot of promise. I would say then the downside is that it's just Jeannie Chan and I. And so we don't have the resources to go through all those alerts every day and then spend a couple hours or an hour even together going through the interventions. So we try to get the high points, the most important ones, or the ones that feed into the overall educational missions we put into place as the priorities. I don't let Jeannie's here if she has any comments.
Yeah, I actually wanted to add that, our clinical pharmacists are really our partners as well, too. So both UWMC and Harborview has a clinical model where the majority of the medical services are followed by a team pharmacist. And they are really kind of our eyes and ears out there because they really bring forth the issues that they are dealing with on their services to our attention, just so that we could really review those cases and, with an ongoing discussions to make recommendations to them. So I do want to say that, it's really, they've really been very, the clinical pharmacists on the team has really, really been very helpful in terms of really trying to help us filter out and screen out, the interventions that we need to pay attention to, because, it is virtually, as what John alluded to, impossible to be looking through every patient's profile, because about, half of the patients in the hospital are on some kind of antibiotics. So it's really, I think it's a partnership working with some of the pharmacists to really kind of fine tune the priorities that we need to focus on a daily basis.
So by giving it to the clinical pharmacists, we're also sort of the interventions almost coming from within the team. So when they're rounding, the clinical pharmacist can bring it up. It has the backing of, the antimicrobial stewardship program, but it's also coming, the discussion can happen on the team. So I totally agree with Jeannie how this is there's many partners here. Jeannie and I form the core of it, but the clinical pharmacists play a big role.
And you show a good way how your model can be adaptable to your situation.
What's the question again?
Oh, I said your model shows how you are adapting to your current situation and how you communicate effectively.
Exactly. I think as Mike mentioned, I think there's a lot of ways to do antimicrobial stewardship. And that's why I think recognizing what the major issues are at the very beginning of this, and that's why I talked about John's slide about stewardship, about the definition of antimicrobial stewardship, what the reasons why we practice antimicrobial stewardship. And so sort of taking that 30,000-foot view, I think there's lots of ways to get there and lots of tools.
This is Tina, and I'm just looking at the time. We're about 4 minutes to the top of the hour. And I do see a question in chat, and so I thought I would call that out and ask for perhaps a quick response. And then if there are any additional questions, I would be happy to have you send them to me, and I could help coordinate responses to those just so we can keep on everybody's schedule. The question in chat is, has anyone found serial procalcitonin levels useful as a bacterial biomarker tool for lower respiratory tract infections and or sepsis? What limitations have you identified? I'm not sure if that's a question that can be answered succinctly, but I wanted to toss it out there since it was put in chat.
Well, I know that we're definitely looking at it, as I think a lot of antimicrobial stewardship programs are, but I know that John Zarek and John Pauk are on the line, and I'm pretty sure that they're either using it or about to use it.
Active with the procalcitonin over the past month, and we're happy, to share experiences and get more of it with other people who want to call in and ask about our program, how it's working. So we can give you an update, hopefully in the next couple of months, what kind of successes we're seeing.
Fantastic.
This is Mike Vance. I just want to also give a plug that we do have a group that the antimicrobial stewardship group of Seattle, and this is a group also that the goal of this is really to share and spread innovative ideas and data and things that's worked and haven't worked. And so we certainly are open to working with any of our other partners across the states.
If you send email to John Lynch, JB Lynch at UW.edu, we can get you on the listserv for the Antimicrobial Stewardship Consortium. We're probably Jane's also online here, and she helps us with that. So just feel free to shoot me an email and get you on that list.
Thanks so much for that offer, John. That's great. I'm going to go ahead and advance us to the last couple of slides to close on out. Each of these webinars, we've provided a little bit of suggested homework. As a reminder, prior to the start of this web series, we had folks do a self-assessment of their kind of current state of antimicrobial stewardship, what's in place, what's not. And then at the end of each of these webinars, we just suggest that you revisit that current state and just look at a different section and ask yourself some questions before the next webinar series, the next webinar. And here I'd encourage you to look at the evaluation metrics section with your team or your partners there and ask, what metrics might give you the most leverage with senior leadership for additional support or resources. Think through how you report these metrics, who do they go to and how often. Are they going to all those potential people that they could be? And to identify perhaps one refinement you might test between now and the next webinar. I will shoot out, actually John, Dr. Lynch, if you could type into the send to all participants chat box your email, that would populate it for everyone to see. This is a pitch for our next up in the series. We'll be heading to Walla Walla on April 25th for yet again a different approach that will look different from the three we've seen before. I'm very excited about that. And then finally, a big thank you again to everybody who attended today and our panelists and presenters. As you leave the webinar, you'll see a survey, and I'd encourage you to take a minute or two just to fill it out so we know how we can improve on our end on delivering the information. And I believe that takes us to the top of the hour. Do feel free to be in touch if you have additional questions or a desire to share or ask for information. I will be sending out a recording link to today's call once it is available in a couple of days. And have a great day. Thanks so much.